So this time we'll concentrate more on the complexities. So I'll talk about vascular complexities, a little bit more about donor size mismatch, and about small donors and unblock, and one other challenge that I hope you'll find interesting. So I'll start with this 8-year-old boy with bilateral renal dysplasia who had been on PD dialysis for many years and had some lines in the neck and femoral areas with no clotting abnormalities. Now, this was had an attempt at transplantation at a different center 4 years previously. And after making a midline incision, they couldn't find any vein that would be adequate for transplanting the kidney. And therefore, they closed and they waited for the child to get a little bit bigger. And then they sent it to us. By that time, luckily the child was 18.5 kilograms. And the other good thing, and as we indicated yesterday, we were not sure where to put the kidney, explore the child first before taking the kidney out from their dad. So this was the scan of that child, and you can see on the left is the arterial tree, so you can see the aorta and the common and external iliac arteries, and on the right, what can you see? Is the venous side. So there's only this bit, this part of the external iliac vein, and then it dives deep into the deep system and then joins the azygous and hemiazygous system. So we only really had one landing spot, but anyway, we thought we'll do some homework first before we go in, some more imaging. We spoke with with Nigel Heaton, that you met yesterday, and on the day of surgery, we got some extra vessels, conduits, as Nigel indicated yesterday, and these were blood group compatible, of course. We had lots of meetings, and if I can show you these sort of vessel diameters that we had, I just concentrated on the left external iliac vein. That was essentially the only thing. Potential thing that might keep things straightforwardly. So you see the diameter was fine, but the length was not long enough according to the Doppler. And we had other options though, portal vein, SMV potentially. And indeed Nigel's view was to try the SMV, even though in some other centers they might prefer the portal vein. Anyway, so we explored the recipient first. And this time we did a left fossa modified rather for Morrison incision to expose the iliac vessels. And you can see the slings around the common iliac artery on the right and the internal iliac artery in the middle. And the blue sling is around the vein. And you can see where it becomes a bit white. It sort of becomes a bit narrower, and sort of that's where it dives deep into the pelvis. But we thought there was, probably 1.5 centimeters there of length to play with. So we called our surgeon at Guy's to take out the kidney, and then we benched it, as you can see here, and then put it in. And you have the head on the right and the legs on the left, and you can see the ureter on the left as well. So we're able to utilize that external iliac vein, and didn't have to go into the abdomen, which would have been full of adhesions as well, just to try and find the SMB. Now, when we closed, we did the ultrasound scan. That was a bit, it was not good actually. So we had to open up again. We did open the peritoneum and tried to create a bit more space for the kidney. And then did the scan, did the scan again, it was all fine. And you can see day one carrying down to 36. And all these kids tend to go to the intensive care unit for the first day. But within another day, he was up in the ward and no problems. And he's still doing well. So when you get these cases, again, there's a lot of multidisciplinary approach to it. We wrote a few of the difficult vascular cases we did here in this paper. This particular child came from Europe, actually. I was a 6-year-old with a previous supraceliac to distal aorta bypass, which you can see. Let me see if I can show it here now. So that's the graph there. So it's only a little bit of artery, aorta left at the bottom to use. So we utilize that. And from the venous side, it was the only vein really was the left gonadal vein that was draining into the left renal vein. You can see it there. And next one was this 17-year-old with previous aortic coarctation and surgery for that, as well as augmentation and reaugmentation and Mitrofanov, and also had a narrow aorta, and you can see here in this MRI. And in this case, we utilize a deceased donor iliac vessel, you can see on the top, to do a jump graft between the supraceliac aorta and the kidney, which you can see on the left here. So that's the transplant kidney, that's the jump graft. And in this same paper, we talk about the classification system with respect to the aorta and IVC, labeled as A and B, to indicate the patency. A1, B1 being normal, and the worst being A4 and B4, as you can see here. As we said before, we could have utilized the portal vein potentially, like in this paper, the SMV, as in this paper. Orthotopic transplantation has been done before, as you can see here, or in this paper from the US, where they use the sort of junction between the IVC and the right hepatic vein. Now, going back to the size discrepancy, I've showed you yesterday our results between less than 20 and more than 20 kilograms. These are our results less than 15 and more than 15 kilograms. And again, there was no significant difference between the two. And I've already mentioned that, the smaller the child, the more likely we'll do a midline incision and anastomosis onto the aorta and IVC, as you can see on the right. And you can see here a kidney into a small child, and as you can see, it takes most of the abdomen. And then it gets a bit tricky to try and close, but usually we're successful, as we talked yesterday. But we always do a scan, as I mentioned before, because occasionally it might be abnormal. There's a bit of a squeeze, like in this case where we have to open up again. But essentially we use this so-called stratis mesh, which is a porcine dermal acellularized mesh where essentially cells from the recipient grow into. And we've had good success with those ones. We do use 3D printing, as George indicated yesterday, and this is me trying to decide where to put a kidney in a young child from Evelina. And that's the young child after the surgery with a 3D model in the Royal College of Surgeons of England. And I'm glad to see that he's grown up a lot. And that's his mum, and Pankaj, one of our colleagues. And Pankaj led this paper where we wrote a few more cases where we used 3D printing. On the top is the first case we actually did it prospectively. Again, it was a small child, a small recipient, and her dad was giving her a kidney. The second one was abnormal anatomy, so the aorta was splitting higher up and rotating. And the second and the third and fourth, it was aneurysmal disease. So this is a young child on the right, comes from Belfast, and her dad, and her 3D models in the Science Museum. Now, we've looked at the UNOS data with respect to assessment of the donor-recipient size mismatch and outcomes, and we use the body surface area index, which is donor body surface area over recipient body surface area, and the smaller the recipient, the higher the value. As you can see here, divided into equal or less than 1, less than 2, less than 3, or more than 3. And more than 3 is sort of the smaller per recipient. And smaller recipient is indicated by the yellow line here, so they have better graft survival, and this is the following living donation. This is after brain dead donation, disease donation. And this study concludes that graft survival is significantly improved when the donor size is more than twice the pediatric recipient size. Also, delayed graft function and primary non-function rates were similar in these groups. We did the same or similar study in the UK, and out of some 1,340 transplants, we divided them less than 15, more than 15 kilograms in weight, and there was no difference in survival, patient survival, no difference in immediate graft function, but there was improved long-term graft survival in kids with a weight of less than 15, because there was more kidney mass. Now, we also had a look at the 10-year kidney transplant outcomes on utilizing pediatric donors in the UK, and we divided that group of patients into less than 5 kilograms and more than 5 kilograms, less than 5 years of age and more than 5 years of age, and whether they were DBD, DCD, and also en bloc or single. And you can see here, with respect to the less than 5 years old donors and more than 5, the outcomes were similar. With respect to DBD and DCD, again, they were similar. And with respect to en bloc and single, were similar as well. And interestingly, on the en bloc, you can see that the very beginning of the Kaplan-Meier curve is a bit reduced, and that's because of because there's always a bit more loss of en bloc kidneys compared to standard kidneys. And I'll talk a bit about that later on as well. So this is one en bloc we did 2 or 3 years ago at GOS. The issue with it, or the unusual aspect, was that they were taking small bowel as well, and liver and everything. So they were very generous with their dissection. So they took the aorta up to the renal vessels, the renal artery, including a bit of the right renal artery. So I couldn't close it, without narrowing the vessels, the top part of the aorta. So took part of the aortic arch and joined it to the top of the aorta, and covered a bit of the renal artery just to extend the tube of the artery, so I can close it at the top. And you can see this here. See the sutures in the middle of the extension. So then you can oversaw it to close the aorta and do the transplant. And it was successful. Interestingly, though, when we did the scan post-op, one of the kidneys wasn't as good. So again, we opened up and opened the peritoneum and put one of the kidneys in the abdomen, and it was fine, as you can see here. So both kidneys growing over the next 40 to 50 days, and really good GFR. Now, talking about en blocs, we again reviewed the UNOS data, and we had 194 out of 23,970 pediatric transplants that were en bloc, and some 6.7% had graft thrombosis versus 1.9% in the non-en bloc cases. And this was significant. And this is the Kaplan-Meier curve, and you can see that drop at the beginning because of this early graft loss in the en bloc cases. But the overall graft survival was similar, as you can see here, and patient survival. Now, the other interesting challenging case we did was this simultaneous kidney and parathyroid transplant. This was when a child who had a living donor. Her dad was going to donate a kidney to her, and she also had this condition where there was a defect in the activating pathogenic variant of her calcium sensing receptor. So she was hypoparathyroid for many years, and essentially she was carrying an insulin pump with her for about 10 years, where there was a PTH, a synthetic PTH in it, and that was given to her continuously. So we decided to take one of the parathyroid glands of the father as well, and transplanted at the same time as the kidney. So after I finished doing the nephrectomy, left nephrectomy, we flattened the patient, and I did a one-gland parathyroidectomy, as you can see here. And the way you do this is by then dividing the gland here in 11 pieces, and then going across to Evelina Hospital, where you can just put it into the rectus muscle that's already exposed from your transplant. And you can see that here being implanted into the muscle. And the muscle is well vascular, so you hope for the blood supply to grow into the parathyroid glands. But of course, it doesn't happen quickly, so you keep an eye on the PTH every day, hoping that it will start going up. And you can see the creatinine did come down very nicely at the beginning, and then after a few days, the PTH started going up. Because of the synthetic PTH not being picked up by the assay of the lab, you can just pick up the natural PTH when it appears, as you can see here at the bottom graph. So that was a very interesting case. Of course, it took a lot of MDMs and getting permissions from GSDT, the Guy's Hospital, let's say, and St. Thomas's management ladder, Evelina ladder, NHSBT ladder. Anyway, it was very successful. So glad to be able to share that with you. And that's it. Thank you.
Great. Do we have any questions?
Yeah. Stuart.
It's really interesting. A few of them I've seen before, and it's really nice to visit them if they're so interesting. The one with the absence of the venous system in the age that going on to the
Externally.
No.
Was there any concerns about the drainage into the esophagus system and things like that? Because we've had one child in Leeds where we've had this. I think we actually spoke to you about it, and that came as a bit of a surprise to us that all happened. And do you do any assessment of it, or is there any assessment you can do, or just have to hope for the best?
What we did was, once we were in the abdomen, we put a needle onto the vein and checked the pressure, and that was fine, and we felt comfortable to proceed. I know in Glasgow they use they do some venography beforehand, before transplantation, to get that information. Yeah.
Thank you.
Hi. I have a lot of questions actually about en blocs, but I won't ask all of them just now. But the one question I will ask is that en bloc that you did do with
Extra cuff.
with where you needed the extra cuff. How old was the donor? And
It was just over 2 years old.
okay, and the weight?
The weight was, from memory, 15 kilograms.
Okay, so is it 15?
Yeah.
Thank you. I'll ask you the rest later, Edgar.
Thank you. No problem. Yeah, George.
From what Sergio showed us yesterday for the closure of the abdomen using the posterior rectus to see it, do you think that in the case that we have a small child that may, deceased donor, I mean, that may need a mesh, should we ask the retrieval team to send us the
It's a good point.
rectus muscle and sit and use it just in case?
That's an option we can do. Having said that, one of our colleagues here once asked for abdominal wall to come with an SPK, a kidney pancreas, and then we didn't use it. So I think you need to, if you have, for example, a particular case that you think you need it definitely in advance, then I think that's an option, yeah. But I wouldn't keep doing it and not using it now. That's the thing.
Consent from the donor
A couple of years,
Yeah.
yesterday we was on a retrieval with the small bowel tumor. They take that routinely, but they actually, what's interesting, what they do, they take the sheath and they leave behind the subcutaneous fat skin. So there's a big defect in the donor. They just close it as normal, and whatever externally appears normal, but they then leave this sort of vascularized sheath or rectus muscle and anterior posterior sheath, which they can then take off. But you're right, you should ask quite a bit too. It's not something I've ever done before. It's something I would, you could probably do if you've done a bit. It's not complicated, but it's just sort of not every retrieval team necessarily comfortable with that because it's usually done by the multiple.
Yeah.
Yeah, so you may struggle to find someone who's willing to do it. And yeah, just,
Yeah, I should have a high chance to use it. Otherwise, it's
probably need to get specific consent for the donor family, I would imagine. Again, that could all be
done. Thank you very much.
All right, thank you.